So I just want to talk to you about the actual alignment process, and then at the end say a few words about the platform, the Envista platform, and just a few words about the Envista Toric. Next slide. These are just my financial disclosures. So here you've sort of seen this to a certain extent. This is the trial a study which was already alluded to, which by Hoffman, showing that we have quite a few patients with significant astigmatism in the cataract population. And that also is a reason why we are increasingly using toric IOLs or also incisional techniques. So we've spoken about identifying the steep meridian, meaning measuring the cornea, calculating the toric power, and now I would like to talk about marking the meridian, some intraoperative pearls, and we'll have some slides later about the actual stability. So here, that has already been said, 1 degree off means about 3% loss of your toric power. So that's obviously very little, but if you are 10 degrees off, and that's only a millimeter at the limbus, that's not very much, you already lose a third of your toric power, but you still may have a happy patient. But if you're more than that, I think then you're in trouble, because not only does the patient he still has the same amount of astigmatism, but he actually also has an axis flip, which patients usually don't like. So really it is about trying to stay definitely below these 10 degrees off alignment if you want to have a patient with a relatively good outcome. Next slide. So obviously exact placement is critical. Now one of the problems is cyclotorsion, which has already been described, and on average that's about 4 degrees. And actually there are outliers in the literature which go up to 17 degrees. And also, even if you think that the patient may not have cyclotorsion or you don't care about cyclotortion, if you don't mark the patient beforehand, you have a problem, because usually the patient will already be draped, and then you have to actually align the lens or align the horizontal. It's actually not even easy to say that after draping. What is the horizontal in this patient? Next slide. So here, just from the literature about just cyclotortion, and you can see cyclotortion 2 to 4 degrees and outliers up to 17 degrees. So this does happen, and it can be in or ex cyclotortion, and that will depend from patient to patient. Next slide. So what we do currently as our standard protocol, because it's pretty straightforward and simple, we just use a slit lamp. And now that may not work in all centers, because sometimes you don't have a slit lamp available in your operating theater or close to your operating theater, but if you do, I think that is still the most straightforward procedure. So what we do is we ensure that the patient has a straight head position in the slit lamp. We take just a normal, long, thin slit, and we make it horizontal and have it retrograde. So then we have a nice line through the center of the pupil. We obviously try to center on the pupil. And then we use an insulin syringe or a subcutaneous needle, and we actually mark the horizontal at the limbus. We make 2 small microerosions, small scratches. And typically what we will do is actually we will put some blue color on those, because otherwise you may, if the patient doesn't go to the operating theater straight away, but maybe to the operating theater after half an hour, after 1 hour, you may actually have difficulties finding these small microerosions. So it's good to just put a blue blob on top, but you will still see the microerosion, so that is very precise. And that for us has worked very well. Typically we will just mark the horizontal 0, 180, and sometimes if we had difficulties doing that, we may also take the 90 degrees meridian. Well, what I also tell this is done by our trainees, so we train up the trainees, so they have to do a few of those to have the first learning curve, and then we check them, and if they are really horizontal, what they do is in each patient which they've done, they recheck at the very end, and if one of the 2 marks is not exactly in the horizontal, they will just put that on our IOL master printout. They will just indicate temporal blob, or temporal, in that case, microerosion is 0.5 millimeter below. So that's good for the surgeon, because then you can take that into account when you're actually doing when you're using the Mendez marker intraoperatively. So these are the kind of markings you see here. Now we've done a trial where we've actually compared it with other marking devices. So here a pendulum marker. Next slide. And then here with the Newitt's Lane bubble marker, which you also put blue into blue ink and then have a bubble, and it gives you 3 markings. And the tonometer marker, which was just alluded to by Goyder, the 2 mark. And next slide, please. And what we did is we just had trainees who had the same exposure and the same training with each of these markers. So they had 15 goals they had with each, actually mark patients. And then we took photographs straight afterwards. And you can see what we looked at is obviously the actual rotational misalignment and also the vertical misalignment, because that can be quite troublesome if you're in the operating theater, even if it's horizontal, but it's slightly off, either vertically below or above. It can make it more difficult during surgery. Next slide, please. And what you can see here is that actually the pendulum marker did very well. Next slide. I'll show that as next slide, as box plots. Next slide, please. So here you can see that the box plots for the slit lamp, pendular, bubble, and tonometer marker are actually, these two are pretty good. There is a difference between the two. The pendulum marker doing better than the slit lamp, but actually the other two in our hands were worse. We had more variability. So from our point of view, that means if you're in the operating theater, we actually use the pendulum marker if the patient was not marked beforehand, but still we actually adhering to the slit lamp marker. Next slide. Because it turns out that the vertical misalignment was actually the best with the slit lamp. Next. So here as a box plot, you can see that the vertical misalignment was least with the slit lamp. So for us, from that point of view, that was the most practical to use and also very precise. Next slide. So if you want to get really a more technical and more fancy, the way to go, and there is a few systems out there now, the SMI system from Berlin, which has now been acquired by Alcon, and this system, which I'm acquainted with from Zeiss, which is going to be marketed this year, if I'm correct. They use an IOL Master 500, which is slightly adapted, which takes a photograph of the vessels. So this is a red-free photograph, and the vessels are photographed when you do the biometry. Next slide. And what you can see here is that this image is imported into the computer, which is connected to the Lumera 700 microscope. Next. And the alignment is made between these vessels and the live image from the microscope, and the surgeon sees through the right eyepiece a superimposed image of the lines of alignment. So that's quite neat because you don't need to look to the monitor. You can actually do everything straight through the microscope. Next slide. So here you can see, for example, this is an example with this vessel here, and obviously all these vessels are recorded. Next slide. And then this is a superimposition of the live image of the operating microscope and the photograph taken at the IOL Master before surgery. And you can actually see the vessels. This is sort of the limbal, the perilimbal area put into a straight line of the two photographs, and you can just do a double check. Next slide. And then this is the kind of image you see as a surgeon. You see the horizontal line, and you see the superimposition of this, in this case, the meridian, which we're aiming for, which you obviously have to enter into the system. And then you can align and there's a tracking system. That means if you're moving the eye during surgery, this will track and auto-track all the time, and you can align very precisely. Next slide. And again, just to remind you that 10 degrees, which we said is really the limit. I mean, you want to go definitely below 10 degrees if anything possible. I think you should aim for 5 degrees off at the most. Obviously, you're trying to aim for exact precision, but I think 5 is probably what you can tolerate. 10 is the most you can tolerate. Is only 1 millimeter at the limbus for a normal-sized eye. Next slide. So I think intraoperatively, obviously, this is not rocket science. This is nothing. The surgery is the same as always, so it's pretty straightforward surgery. All you need to do at the end is you need to be as precise as you can and take some time. So I think it's important that once you've implanted the lens, you really want to do a complete viscoelastic removal. I will only use a cohesive viscoelastic when I actually implant the lens in these cases, because I want to be as complete removing the viscoelastic as possible, because you don't want to have a cushion of viscoelastic behind the IOL, because that may allow the lens to rotate on that cushion within the first few minutes or hours after surgery. Also, you want to rotate, obviously, the lens to the correct meridian with, you can use a bimanual IA, obviously you can also use a coaxial. Then I, as I said, remove the viscoelastic from behind. And then what I do is I typically will hydrate the paracentesis and the incision, so I'll have a firm eye, and then I'll do the very last fine-tuning with a 30-gauge cannula through a paracentesis, which will allow you to really just give the lens that very little, these last 2 or 3 degrees, 4 degrees, whatever it may be, to that nudge to actually put it on the right axis. So what I'll always do is I will use the Mendez marker again. I will put it on the eye again, even though I've done markings in blue before. because sometimes the lens is not centered on the cornea. It's, typically the lens is slightly nasally, and that can be variable from patient to patient, from eye to eye. So typically I'll put the Mendez ring on again, and then I will fine-tune as well as I can. Just a word of caution, in a high myope, you have a higher probability of having a big bag. And if you have a big bag, what you really want is you want a fully extended lens. Now, all these hydrophobic acrylic lenses with their open loop haptics, such as the Envista Toric, all of them take a while to really extend to their full size. So you have to give them a little time. Now, in a normal eye, that may not be such an issue, but if you have a very big bag, you really want to wait a little. So sometimes it actually makes sense if you have a very big eye with a big bag, and you can see the lens is moving relatively easily. You really want to give the eye maybe even 1 or 2 minutes. Put the lights off, wait for the aqueous to warm up, or the BSS inside the eye to warm up, to allow the lens to fully extend, and then actually do the fine-tuning, and that may make it a little more safe. Next. So this was my strategy about a year ago, and at that point, and I've changed my strategy slightly. What I've said is incisional techniques and toric lenses. I think under 1 diopter, I think there's not much of a discussion. I think incisional techniques are the way to go. You just do an on-axis incision, and I also like to do opposite clear cornea incisions in low astigmatism because I think they're quite effective and they're cheap. And then I used to use LRIs. I've actually stopped using LRIs for 2 reasons. I've had, 2 patients. I've had 1 patient with severe dry eye after that, because obviously you're cutting a lot of nerve tissue. And I've had another one, unfortunately, with an infiltrate and actually an ulcer in the LRI. That was last autumn. So I'm really reducing my LRIs very, very rapidly now. And I guess that will allow us to think about using toric lenses at much lower rates. I mean, in the US, it's quite common to have toric lenses in between 1 and 2 diopters. I think with multifocals, it's something we use readily. But I think now, we're getting much more sort of used to toric lenses. I believe now the toric lenses will be moving into this 1.5 to 2, maybe even 1 to 1.5 diopter segment. Next slide, please. So just to summarize the first part of the talk, which is really about identifying the meridian. I think that has been alluded to before. Incisions, I haven't shown you any data now, but we know that they're less predictable, and I just told you about some of the problems for LRIs. The toric IOLs, definitely, for me, at 2 diopters above, it's clear is where I would use torics. And I think now we're sort of talking about the area of 1.5 to 2 diopters because of the problems with the incisional techniques. But I also would recommend one thing. It also makes sense to leave a little astigmatism, at least in one eye, to undercorrect slightly. And that is because really much of patient satisfaction is about functional vision. And we know that if you have a little residual astigmatism, that can be very helpful to give you depth of field, because obviously you have some depth of field through that. And I think that's something you always have to keep in mind. You may want to keep one eye slightly undercorrected, and I think that makes sense. Marking the meridian I told you about, and placing the torus on meridian. And again, precision is really key with this kind of surgery. Now let me, next slide please, introduce you to the Envista. This is the platform. This is the now non-toric or non-toric version or aspheric version, 0 to 34 diopters. It is a hydrophobic acrylic material, obviously with a UV absorber, 6 millimeter optic, 12.5, so very straightforward, open loop design. This material has been around for a while, so people like Manfred Tetz from Berlin have tested these materials and have long-term follow-up, and he may want to discuss that in the discussion section later, where this material has been shown to be glistening-free and also very, very stable. Now, next slide, please. This is the toric variant, and you can see these are the cylindrical powers on the IOL plane, 125, 2, and 275, corresponding to these cylindrical powers on the corneal plane. And otherwise, the design is the same. Obviously, you have 2 lines to show you the alignment axis. Next. Here again, some of the material benefits. I don't want to go into all the details, and I think most of you know this lens, so that's probably not so. But I think one of the things we are all quite interested in is that it's actually in fluid before we do surgery, so it is prehydrated, and we have not seen no glistenings with this lens until now. And that's obviously an issue, as you know, with hydrophobic acrylic lenses. Next, please. There's also a 360-degree continuous sharp edge. There is a stepped haptic, and you can see here that this sharp edge is supposed to, again, help to stop LSC progression or proliferation behind the lens. And it has a very sharp edge, which we know is important. It's not only having a sharp edge, but you want to have a really sharp edge to have this lens epithelial cell migration barrier. Next, please. This is a very nice slide from David Spalton and his group, where they took standardized photographs, slit-line photographs, did some image processing to actually look at glistenings. And we know that glistenings are very common, especially with one of the competitors. Next. So here again, some of the patient benefits of using the Envista platform. And again, I think most of you know about these. And I think most of these have been alluded to. Next. And that's actually the end. Sorry about that. Thank you very much for your attention. And we'll continue now and then have questions afterwards. Thank you.